Awesome. Thanks, Ashley. Thanks to our supporters. Is it you guys okay if I do some shout outs real quick? Sometimes we
Sure.
do some shout outs. We have most of you don't know this. Ashley knows because they've been with her today, but we have the AASPT traveling fellows for fall 2024 in the middle of their rotation right now. They were with Bob Mangine in Cincinnati, and the last couple of days they've been with Ashley and Mike, and they're going to Delaware. And the three, supposedly they're watching. Do you know, are they on, Ash? Mike told me they were going to be on.
I think they might be looking as a group because
Looking
I
as a
do
group.
see,
Okay,
yeah,
so
because they're staying together.
Ojere, Streeter, Polo Edwards, and Haley Hoer. I hope I'm saying her name right. Haley Hoer, Hoerr, however you pronounce that. And then I've got to also give a shout out. We were at the ISHA meeting this weekend, and we met a guy that said he's been to he's a 90-pluser, Phil. I think that means he's been to at least 90% of the journal clubs.
Nice.
Wow.
Big, cool dude named Adam Rosowski was with us this weekend at the
And Adam is on.
meeting. So,
I see him
and
on.
Adam
I
is
see
on.
Adam.
Awesome. Adam, shout out.
Way to go, Adam.
All right, guys, we got great night tonight. We've got topics we haven't had before. We got ankle and foot topics, which I think are going to be awesome since we haven't ever had it. Looking really forward to this. I'm Rob Manske from Wichita State. Shout out to my students if they're on. Barb, you want to introduce yourself real quick?
Sure. I'm Barb Hoogenboom from Grand Rapids, Michigan, editor-in-chief of IJSPT, and shout out to my students and former students who might be on as well.
Phil, you're up next.
Okay, shout out to my students. I'm from Fran U in Baton Rouge, but also from my Louisiana peeps out there who are attending. I just wanted to say thank you for that. And Ashley, again, thank you for pulling this off, and for our sponsors. And I always love when Ashley starts a meeting. Everybody behave, okay?
Yeah.
Yes.
What number are we at?
What number do you think we're at, Philly?
29.
Oh, you're so close. So close. Number 30.
30.
Number 30, 30. All right,
30.
let's get to our guests. I'm gonna introduce Danny Lorenz. Dan, how long have we known you, Danny? You've been when did you start working in Kansas? How many years ago?
2005.
2005. I thought it was even before that. But
yeah, no, but I got to know you probably early 2000s.
Yeah, it was pretty early on. I've known you forever, man.
And
But
Barb
I
has
knew him when he was
Barb
a
has to claim me
baby.
as a student.
Yes,
I knew him
she
when he was a
telling us
baby.
earlier.
Yeah.
She was telling. She said she's going to tell some stories, some student stories
Nice.
before we're all done.
I can't confirm or deny any of them.
For people who I can't imagine there's anyone listening that doesn't know you, Dan, but tell everybody where you're working now and who you are, what you're doing, all that kind of stuff. And then if you don't mind, since you know Dr. McCullough the best, do you mind introducing him as well?
You bet. Well, first off, thank you for the kind invitation to be here, and you could ask a lot of people, so thank you. But I'm the director of sports medicine at Lawrence Memorial Hospital in Ortho, Kansas, in Lawrence, Kansas. I'm also the program director for our the LMH Sports Physical Therapy residency. We're on our third resident right now. And I'm happy and privileged to introduce my friend and colleague, Dr. Kirk McCullough, here in Kansas City. I work with him directly a lot on a lot of high level folks and average people, or just average Joes as well too, and average Janes. So anyway, he does an outstanding job. Patients love him. He teaches at we do a sports medicine symposium every year at LMH, and he's gracious to make the trek up to Lawrence every year, and his talks always give high marks. So I anticipate the same thing here this evening. So Dr. McCullough, thank you so much. And he's on the NFL Foot and Ankle Committee, team position for Sporting Kansas City, one of them for the Major League Soccer team here, and he's got quite a resume. So it's a real privilege to have him.
Yeah, well, thanks to both of you. This is we've been looking forward to this. This is going to be great. Thanks, Dr. McCullough, for showing up with us tonight.
Yeah.
Tell us, can you tell us? Do you got any stories about Danny you can tell us, or if you don't have any good stories, just tell what is it like working with him?
Yeah, I mean, so obviously having someone like Dan in the region, Dan's one of those guys that, so when I came to Kansas City, we connected through the Chiefs, but, he was running a private clinic out in South Overland Park where I live, and, garnered up a great reputation. Ultimately, as we all know, with business and things, there was the clinical stuff is great, and it's always the business details that ruin what otherwise is a great clinical practice. So then he got recruited to Lawrence. But Dan's one of those guys where I've got 10 minutes, 15 minutes with a patient, but I'll spend 5 minutes trying to convince them that it's okay to drive 50 minutes west to go see Dan.
Yeah.
And that the drive is worth it. So as you all know, Dan's one of those guys. And certainly when there's a problem that no one else can fix, who you going to call, it's Dan Lorenz, at least in the Kansas City area.
He's just like the Ghostbusters, man. Who are you going to call?
Right. That's
Dan.
right.
That's
So
right.
no, it's been great. I've actually had the chance to lecture with him, along with him a few times, which has been really good. And whether it's going and lecturing to foot and ankle folks, knee and shoulder folks, athletic trainers, PTs, just love the opportunity to continue to try to collaborate and figuring this out, because in the end, taking care of athletes and the now weekend warrior pickleballers that have taken my 30 to 4-year-old Achilles ruptures that now are 40 to 6-year-old pickleballers. It is a team to take care of everyone's expectation, whether it's their own or whether it's the GMs above them. So yeah, excited to chat about these two tough lower extremity injuries.
Yeah, no, these are great. Well, you guys want to start? Let's start. The first article is by Christopher Laprade, I believe is how you pronounce it, and
yeah, it's
co-authors.
Laprade.
Is it Laprade?
It's Laprade, and it's his son who wrote the
article. Okay.
Rob Laprade's son.
Yeah, we had him on just like a couple months ago. So I thought surely that can't be the same pronunciation. Can't be.
It is.
I didn't know his son
No.
was a doctor. No. Awesome. So the title, Return to Play and Performance After Operative Treatment of Achilles Tendon Rupture in Elite Male Athletes, a Scoping Review. And my first question tonight is going to be directed to Phil. Phil's kind of our stats methods guy here. And so Phil, my question to you is, can you tell us what's the difference between a scoping review and a systematic review or a meta-analysis or something like that? Is one of them better? Is a scoping review actually better, or is it?
It depends on what you're trying to do, right? So with everything else, we're used to systematic reviews, right? So systematic reviews are going to have a very focused question, typically comparing things, usually randomized controlled trials, high-level journals, those types of things, very specific inclusion, exclusion criteria. Now, recently, it's probably 10, 15 years, this concept of scoping reviews have come out. You may also hear of them as called umbrella reviews. What they do is they broaden the scope of the review, and a typical systematic review would include your randomized controlled trials and potentially an observational cohort, but usually it's a randomized controlled trial. What a scoping review does is it allows you to include more than just that design. You can include systematic reviews. You can include meta-analyses. You can include reviews. You can include cases. You can't do that with systematic reviews, okay? Because systematic reviews are very focused. Why do we use scoping reviews? A couple of reasons. One is typically it's because you have a very new topic that doesn't have a lot that's out there. And so the literature is very sparse. If you try to do a meta-analysis or a systematic review on something that doesn't have a lot of literature, you're not going to find anything.
Yeah.
Unfortunately, we're still publishing systematic reviews of 2, which drives me nuts. They should expand that to a scoping review. So a scoping review, though, its main purpose is to identify what's out there in the literature about a specific topic that is not so rigorously defined by the inclusion-exclusion criteria. And then that gives us the ability to identify where are the gaps in the literature. So the main purpose is really to find out what do we need, what do we know, what don't we know, what do we need to know. That's kind of what a scoping review does for us.
How are you going to get it? Yeah. Awesome. Thanks for
Can I
that
jump in real
explanation.
quick?
Sure. Of course, Barbara.
So the Johanna Briggs Institute has really good guidelines for scoping reviews, and there's a really good article. I have to look and dig a minute, but to compare and contrast scoping reviews with systematic and meta-analyses reviews. I do think that there are ways to tighten up your inclusion-exclusion criteria in a scoping review, but I tend to see them as something that and tries to answer a broader question than a really narrow systematic review. And to your point, Phil, that there may be literature that's not quite as high level that might be included in a scoping review.
Nice, nice. Those are great explanations. Thank you both.
Mm-hmm.
What did you guys think, Dr. McCullough? You can probably jump in on this one for sure. The in this first article, the criteria, and we've seen this before in studies. The criteria for them for return to play was return to at least one game. Is that, what do you think of that? Does that seem like it's adequate for return to play?
Well,
I guess it is return to play, but
yeah. So
one game.
I mean, and I don't want to jump ahead, but I mean, some of this, there's the whole idea of what do we mean in return to play, and it's truly defining that, because there's return to sport participation. So is that return to play? Is it return to competition where you're playing in a game, which in this case you've played one game, so it's return to play as it is return to competition. But then there's also then return to competitive level of play.
Yeah, or
I mean,
previous
that's
level.
the final thing, where it's like, not only are you playing in a game, but you're playing at the level that you had potentially played at before. And the reality with some of these, at least if you look historically, there's concerns: do you ever return to that final phase, or are you always a percentage of your former self? So that's where the consideration is. I think as it relates to sports, obviously returning to practice is not returning to competition. So returning to practice is okay, you can get around to do some things, but at least returning to game level competition, even if it's one. Now, if you turn to one game and then all of a sudden you pull your hamstring or you do something else, I mean, you weren't certainly very durable. So I think it's reasonable, but is it an end all be all? No, I think it's more about what performance is, and you're actually returning to that level of competitive play rather than that you're simply competing.
Yeah, I guess that's kind of that was my point. I think that so you get back to one game, I mean, that's you're right. That's better than getting back to practice, but it's not, getting back to your prior level or getting back to actually full competition. Yeah, you feel.
And as it relates to our patients, ultimately, I mean, once again, whether it's the pickleballer or whether it's an elite athlete, this is all about setting an expectation. And so that becomes the problem with these types of studies is one, have we clearly defined the problem? I mean, we say Achilles injury, but what is it? Is it insertional? Is it non-insertional? How is it fixed? How is it rehabbed? I mean, there's a lot of nuances to this. So I understand the purpose of a scoping review. I look at it a little bit more as maybe a glass half empty. It's kind of a summary statement. It's a Cliff Notes of kind of what's out there, but I don't know that other than just identifying holes or identifying problems, that you're going to look at this and get something that's got some teeth with it and then go back and say, well, I read the scoping review and then this is now the new way to do things.
New way to look at it. Yeah. Good. Danny, do you have anything to add, or you?
No, not on top of
Cool,
that.
Pat? All right. So they also had their return to play in that study was anywhere from 16 to 36 weeks. And I that seems kind of quick to me, but I have to be honest, I don't see hundreds of Achilles tendon repairs each year. So maybe that is that normal time frame? Is that what you normally see with like the elite athletes like this going back that quick after a rupture?
Dan and I have shared a few of these elite guys, so I'm gonna let Dan weigh in here, and then I can come in at the end if necessary.
I would say that particularly with the advent of the PARS procedure as well as the speed bridge, I think that the return to play has been accelerated and moved up probably a few months. In fact, I'm seeing people run like elite athletes running and looking pretty darn good at it at 4.5, 5 months. So they do quite well now. Are they ready for, as Dr. McCullough alluded to, are they ready for practice? Are they ready for competition? That's a different discussion. But I mean, I've had guys ready to go. I mean, ready to go at 7, 8 months. So it's accelerated considerably.
And that's obviously the like you said, the elite athletes. That's not your average Joe that tears his Achilles tendon and is working a regular job. Not a elite athlete. They're obviously taking longer, I'm assuming, correct?
Yeah, I mean, I think it depends upon who it is, what they do, and what they want to get back to. So I think Dan is correct as it looks at the technical aspects of it, but I think the probably even the more critical issue. I mean, the technique, the biggest issue about technique is how do we restore at the end of all of this normal resting plantar flexion tension, period. And so how do we do that within the least invasive or the least complication producing process? So you can do it a myriad of ways, but you got to make sure that you don't create wound issues, you don't create excess scarring, you get the thing probably at time zero over tensioned, because we know from the literature that these will stretch out over the first 3 to 4 months. So this is not matching the opposite side. This is not matching the opposite side at time zero, but instead over tensioning it, realizing it'll stretch out. But the more critical thing is what you all are doing. It's actually I think it's the advent of BFR. So if you have a wound that you can push sooner, get that muscle tendon unit moving, get neuromuscular modulation, getting it firing, even if it's not much, not immobilizing someone for 2.5, 3 straight weeks because you're worried about a wound. Like the faster you do that, we know that quicker motion is, in getting to these tears sooner. So getting at it within 4 days compared to 2 to 3 weeks. I mean, all of those things matter, but gosh, BFR and what you can do to not overload the tendon units, but yet to I'm getting a little feedback, but yet to get muscle firing sooner and minimizing atrophy. I think the BFR is what's the huge thing here.
Yeah. So Dan, tell us what you're doing with BFR. I've got a question coming up for you. You could probably answer this within the question. I was just going to ask you about your post-operative, what you do post-operatively, and what kind of return to sport testing you do for Achilles tendon ruptures. But since Kirk brought it up, tell us what you're doing with BFR with these patients.
I usually wait 2 weeks post-op to let the wounds heal. Just not that there's any risk of clots or anything, but I just think everybody feels a little more comfortable when wounds are closed. So I wait till then, and then I start in the boot. They bike usually 5 minutes on, 1 minute off, and repeat that a couple times. If they could do that every day, if you have somebody that had access to those resources, I would do it. I also start isometrics in plantar flexion, both knee extended and knee bent, to get soleus. We know there's a lot of data on the loss of soleus atrophy over time. And that may, I was going to ask Dr. McCullough about this, and maybe I've even texted you because I like to badger Dr. McCullough on text message a lot with my nerdy questions. And one of the things that I always ask is this tendon lengthening in part due to the fact that we don't get him going faster? Just with there's been a few studies on Achilles tendon forces and stresses with exceeded calf raise with no weight is like virtually no strain to the tendon. So getting it going a little bit faster. So I tend to do BFR with isometrics, like I said, in long sitting with the knee bent, and then eventually, in sitting I'll put a towel roll underneath their heel to keep them in a relative state of plantar flexion.
Yeah.
And then they're pushing into an isometric hold at 80% occlusion. Some people have advocated for doing full occlusion. I don't really have an opinion either way on that. I haven't had a cause to go all the way, but certainly it is definitely a game changer from a standpoint of mitigating the atrophy in the calf, no question.
How long do you do the BFR for? How many weeks do you do it for? You just do it till their point where they can do kind of normal weight, or do you have a normal time frame
To me, it's once I get them on their feet and they're able to do actually push weight, it's a supplement to me. It's always been a supplement to me. So it's something they do at the end of the session. It's also something like some of these guys or some of these athletes will buy units and they'll do it at home. I tell them to do it at home with isometrics, and then when they finally can do standing calf raises and things like that, they'll do those things at home as well. So some of that depends on how much I have them, how often I have, do they have the home unit? Do they not have a home unit? But for me, in those early phases, until I get to 6 to 8 weeks where they're can be standing
so
in
they can
place.
do it themselves.
Yeah. And then like I said, it's the same thing with ACLs though. It's a supplement to me. It's never usually a replacement of what we normally do.
We have I don't know if you've been on here before, Dan, and Kirk, obviously you haven't, but we get questions from the people that are on listening to us. So we've got a couple here. One from Carl Faust. If return to competition should mean you're ready for 100% effort, no guarding, no significant increase in pain. How do we meter the ability to handle return to competition schedule? Meaning like we're using some type of competition calendar. How do you handle them getting back to their, I think he was asking, how do you set them up to return back to their full level, once they're toward end stage, is I guess kind of how I'm interpreting that question.
Dr. McCullough, you want to start with that and I'll round out, or?
Yeah, so I mean, so if it's return to gameplay, meaning so this is, I don't think this is anything necessarily unique to Achilles than it is any other injury, and the ramp up phase as you're starting to do things. So I think it's where you at with your metrics, as far as what you're showing from a speed generation, ability to start stop, what your fatiguing levels are showing. As it relates specifically to Achilles, even going back to the basic things about this, like until they can do repetitive single limb heel rides, there's no reason they should be running. So running is the first thing. And that's, once again, as Dan appropriately talked about, I mean, the soleus is underappreciated. I think the other muscle that's significantly underappreciated is the FHL. So, I mean, there's a lot of things that you can be doing that's working on foot intrinsics and extrinsics, as well as the soleus, that if you are doing those things early on, but then also realizing in what I like to refer to as the runner's chain, there is nothing that's preventing you from working the glutes early on to make sure that the hips and everything are going early on, even when you're not fully weight bearing through the limb. So that when you do start doing that, and what I like to refer to as boot disease, you're trying to minimize the issues of boot disease.
Yep.
So that when they do get out, they're more ready to then hit the ground, literally and figuratively running. As it relates to the expectation of ultimate return to competition schedule, there's nuances as it relates to the different sports. But you got to be able to do the simple things and the basic things. You got to be able to do heel raises to run. You got to be able to run and jog to be able to jump. You got to be able to balance and do things well to start doing lateral movements and change of direction. But that, that gets I get a little bit out of my lane when I start. I advise as it relates to return to competition, but do not mandate. It's simply giving hey, I don't want you doing this till I see this. But outside of that, it starts to go over to the performance folks.
Yeah. You got anything extra, Dan, to add to that?
Yeah, I typically, remember a lot of times in these cases, there's a baseline level of fitness that they need. So sometimes but what I do typically with really any program is kind of reverse engineer it. So what's our calendar? When are we trying to be ready? And then try and work backwards from there to see, how long do I actually have? And obviously that window is shortened if somebody's on a time crunch or ready for a workout or for a team or something like that. But typically a baseline level of just fitness, like I said, so walk, jog intervals. Now, I'm not making an offensive lineman run 30 minutes straight. They don't have to do that on the field, but certainly doing things, like I said, to build up their general fitness with either moderate intensity for longer rest time or longer work times, or short rest periods. And then again, starting to widen that out a bit, and then getting into more position specific things, and then starting to put those things several days in a row. Because who cares if you can do it one day in a row? Because when you get back to it, not only is it games, but it's practices, it's weight room, and all those other things, right? So, yeah, I mean, depending on the sport and all that, I typically what I'll typically do if I have the time is I'll kind of break it down from we move to like individual drills first. How did you react? How was your day after? If those things went well, then you keep throttling up a little bit at a time. But normally for the average person that's not a pro athlete, what I normally look at is what they want to get back to, how many days a week are they practicing, how long are their games, kind of add up the total. It's simple for people to do this. Just add up the total practice and game minutes a week, whatever that number comes out to, and then essentially taking 20 to 30% of that, and then to start, and then you work up about another 20% a week. So over the course of about a month to 6 weeks, you're achieving
back up
that full intensity. But again, it can be accelerated based on how people are responding and reacting to what you're doing,
or slow down.
Yeah,
exactly. Based on how they're doing.
Right.
Yeah.
Right.
Yeah.
I have one comment just quickly on that note, as kind of already alluded to, but this whole conversation is the importance of knowing that there's a whole team of people that have to be involved in this.
Oh, yeah.
And that's where, working with the strength and conditioning coaches, the position specific coaches, the head coaches, depending on what level you're at, in certain levels of high school athletes, we end up quarterbacking it because they don't have someone
Mhm.
do it, but at certain levels, making sure everyone's in the loop, because we'll run into things where, like, we just talked about this yesterday, where a elite level player has a little, like a side chiro or PT or trainer, whoever that they work with separately at certain levels, and you don't know what they're doing over here. So
Yeah,
all
yeah.
of a sudden load management gets all out of whack because you didn't realize that they were also doing double what you already are having them doing. So communication is key, and I think all of this.
Like everything.
Yeah,
Like everything.
great point, Ashley. Mhm.
The an anonymous attendee had a question. I think you got both Dan, you and Kirk answered. I think kind of, has the overall return to play time frame been accelerated to that 18 to 36 week due to progressive rehab versus old school thinking of immobilization? And it's
Yeah, I mean,
you guys can answer,
I would argue yes, and I think part of the reason why it's been accelerated is because of techniques that have lended to less invasive or less disruptive types of interventions to where wounds aren't as big of a problem. They're still a problem. This is high dollar real estate, but when you tension these appropriately, you can start moving them faster. I still get a little bit worried about, I mean, look, the elephant in the room is Aaron Rodgers walking around in a shoe at 4 weeks. Cause like, well, heck, if he can do it, then I can do it. And what people don't appreciate is that there's a rigid AFO that's hidden underneath everything that's trying to protect him. And ultimately, you know, do I think that he probably stretched that thing out a little bit? I think he probably did. Does it matter as much exactly for what he's trying to do compared to a defensive back or a running back or a wide receiver? Probably not, based upon the limb that was involved. But look, I mean, those become new expectations for everyone. So you kind of have to, whether it's Dr. Google or it's, you know, it's I don't know, Dr. NBC or whoever was showing that. I mean, it ends up being that, you know, you gotta try to fight those battles. But the key here is, do not over lengthen it over that first 3 to 4 months, and you have the ability to return that muscle tendon unit to the same potential force generation capacity that it had prior to the injury.
How much, that brings up a good question. You talked about the lengthening, and that's the fear, right? How much do they usually lengthen? Is there a standard amount that, I mean, you alluded to the fact that you over tension a little bit because you assume it's going to lengthen a little bit. How much do you assume it's going to lengthen?
So, you know, the reality is like when I fix these, because look, everybody's range of motion is going to be different. So this is not, okay, well, I'm going to put everybody at 20 degrees plantar flexion because I know that over time that's going to eventually, you may have somebody that 15 degrees is all they can plantar flex, period, because they've got posterior impingement, they've got other, you know, ankle related issues going on. There's no way in heck you're going to get that ankle down that much. So one, it's relative to what their opposite side is, as long as that side hasn't been injured before. And so to me, the way I'm fixing it, and I'm not saying that everyone has to, because it depends upon whether they're going suture to suture or whether they're anchored down to the heel. But I mean, when it's suture to suture, I maximally plantar flex them. And I expect that they are going to lengthen from where I place them. I mean, you know, what that ultimately ends up being in centimeters, I mean, that probably ends up being at least 3 to 4 centimeters. It's probably more with some and less with others. I think this is not unlike when we do patellar tendon repairs or quad tendon repairs. I mean, you get them moving, they're tight at first. You don't lengthen them too quickly, but you also don't hold them immobilized, because you know if you don't, they won't achieve maximal motion. So, I mean, it's a balance. I think the body has an ability to find its true home. You just don't want it over lengthening when the muscles can't prevent that from occurring, and there's no way to protect it. So I think you get pretty mature healing by 3 to 4 weeks, or 3 to 4 months. Sorry. I'm just not purposely putting them on a slant board or other things and trying to say, gosh, I want to match that other side before they get out of a boot, or even right when they get out of the boot.
Yeah. Just let it in time. You got time. You got time to get it.
What are your thoughts?
Yeah. Don't you think the same? You think the same, Dan?
Yeah, I would say it's probably been one of the better evolutions, I think, in Achilles rehab is using the wedges and the boot, and then going into the shoe and the wedges and stuff to keep that thing short. You know, because again, I tell patients, you have to resist the urge to stretch. because it does feel tight, you know, and
they want to.
They want
yeah,
to, and it's
yeah.
like resist the urge till you get to 12 weeks, and then we can work on being able to go downstairs normally and those kind of things.
Yeah. Dr. McCullough, you I assume you track your like re-rupture rates after surgical repair. Do you know what yours are and what are they nationally normally, or
Yeah, I
can
mean,
you
like,
say? Do you feel comfortable saying?
so I can think, I mean, in the last 12 years that I've done PARs, I can think of 4 that not, and so that includes insertional and non-insertionals. 3 of them were insertional ruptures, insertional either debridements or ruptures that re-ruptured because someone was out of their boot and fell. As far as someone who just ruptures on their own, I had one 42-year-old female that I remember very specifically as a teacher, who was the only one I can ever think of as a non-insertional injury that for whatever reason, she did not heal it like I would have expected, and she re-ruptured. And I went back in and it was fine. But other than that, I've literally done hundreds of them and have not seen re-rupture.
So really low. Your rate's really low. Yeah.
Yeah, but that's the whole idea of surgery, right? I think, and so the issue in the literature has never been whether or not re-ruptures with surgery are high. It's, well, yeah, fine, it's great, but what sural nerve issue do I have? What wound problem do I have? Do I ever get to the same level? I mean, that's been all the boo-hoo on surgery. As an admission, I do not routinely treat any of these non-operatively, but there are a couple, and I've got one of them who's the coach of my kids, who I had fixed his opposite side and did great with it. But I mean, he's an AAU coach. That's his life, his livelihood. He ruptured this thing in the middle of June, right before the July open period. And he's like, oh my gosh, like this is everything for me. Like, I cannot have this operated on and not be able to take care of all of these kids. Is there any way in which I could non-operatively manage this? And if you needed to down the road, you can go and shorten it, do an FHL transfer, yada, yada. And so I've done that. He's now 3.5 months out and he seems to be doing okay. Now, is he of the build and everything else where I'm going to be challenging him and he's going to go out and try to play some more basketball? No.
Yeah.
But in general, I have actually taken people treated non-operatively, other health professionals treated themselves non-operatively, and that have either struggled or re-ruptured and then taken them back to revise those. I've seen that much more frequently than the alternative.
Yeah. One of the I thought this was kind of interesting. One of the statements in the study was that the patients won't. There should be an expectation that patients won't get their full range of motion back and their strength back. And that was, I think, based on looking at the studies that they included in this paper. So based on that, do you think that some of these studies had fairly short time frames that they were looking at? Is the reason that people won't get their strength back, or that they didn't in this study, do you think is because of the short time frame of the studies? Meaning, if you have a study that's out maybe 5 years or so, will they get their strength back? I mean, do you see if it's more than a short time frame, do these people usually get their full strength and motion back?
Dan, go ahead and chat.
Yeah, there was a 2017 study that said even like 7 years out, they still have a lack of it. I think one of the main issues is strength and terminal plantar flexion. So having people do heel raises like on a 10-degree decline board, because and what's interesting is you would see that side to side where they have a hard time getting a heel raise up from there. So that's one way you can address it. Or like I said, having them do heel raises from like an elevated heel position, whether it's a rolled up towel or something, if you don't have a decline board.
Mm-hmm.
But I mean, that's definitely an issue and something we need to address.
I'm going to invoke my Karen Silvernagel
Yes.
meme.
Yeah.
And she would, what I think she would say is that it's basically that there is elongation that you've alluded to, Dr. McCullough, and that there is musculotendinous changes that go on throughout this unit. And some of that is like not preventable, no matter how good of a job we do in surgery and or in rehab. And that we are doing our best to mitigate those changes, but they happen like come hell or high water, basically.
Yeah, I certainly think for some folks, there's going to be a relative inevitability of some of that. But I do think that for the most part, I mean, if we look at the studies that were included in a lot of this, as it relates to the advent and the consistent use of things like BFR and less invasive things where we're trying to maximally tension, I still think the existing literature is more evidence of the mass effect of the older ways of managing this than it is the newer. Because with these newer things, and obviously it's a little bit anecdotal, and I'm going to, between the work of Bob Anderson and I with the NFL and what we've seen with what both of us have been able to do in that and soccer, we have certainly seen more people coming back and doing well and not having the same deleterious effects of this injury that Salim Parikh saw from his internet-based study that was the one that was so frequently quoted, or even Jack's study, which once again was another internet-based. So, you know, we have an NFL-sponsored study that is in review with Sports Health. Once we have that out and we're able to kind of talk to this more, the newer techniques and the newer rehab modalities are narrowing the gap. Is everyone going to come back at the same level? No. Does everyone have an ACL come back at the same level? No. But are there people that can, and are there people that can overcome it? And are there ways for both of us on both sides of this treatment spectrum to be better and to do better? Yes. But in the end, the third is that the patient themselves have to do it. Some people just simply fatigue of the process after about 5 months and 6 months when they're not a professional athlete. And the reality is that this is a 10 to 12 month recovery. And most people are just done by about 6. So they get what they put into it.
Great.
100%.
We got another question here from Andrew Broderick. I'm going to shout out Andrew. He's going to be on middle of next year, I believe. We have him scheduled to jump on Journal Club with Dr. Provencher. Andrew asked, with the rapid increase in force plate technology use and the ability to monitor peak force production more objectively through rehab, are there any return to run key metrics that are a must be able to do before initiating light impact and ultimately running? Or if no access to technology, what clinical assessments are a must before introduction? For example, 2 times body weight, calf isometric peak force, or a certain amount of weight of full height heel raises. And Kirk mentioned doing a single leg heel raise. Dan, do you have anything to add?
Yeah. First off, can they walk on the balls of their feet without dropping into dorsiflexion? Can they sustain plantar flexion? That's a quick and dirty, like, do we even have the discussion? Because if you can't even sustain plantar flexion and I mean, it's just you'll be have a raging Achilles tendinopathy at some point. You can't even do that. 10 heel raises for sure. Can they hop in place? You know, can they hop 10 times in place, you know, without collapsing at the knee? And can they truly keep it at the ankle? Because then again, now we're going to develop a patellar tendinopathy because it's decelerating what you don't have to decelerate at the ankle, right? So can they do that? And then when you're looking at like discharge kind of things, you know, or like when you're actually testing them in the absence of force plates, Adam Rosen's study in Clinical Journal of Sports Medicine 2017 talked about doing like a stair hop test. So 10 reps as many times as you can from the floor up to a box and back down. Now, if I have a 300-pound offensive tackle, it might be just a 3-inch box. I'm not gonna put them on an 8-inch like the study did. So who's in front of you, of course. You could do a side hop test, which like you could do 30 centimeters. There's more frontal plane test. Again, it's 10 reps back and forth as many times as you can. So it's again a clinically based test to tell us about our reactive strength. But of course, if you have access to force plates and things like that, the trick with that though, and actually we just had a Journal Club article last week about this. They did a five reactive hop on a force plate. But the problem is, again, is that you got to take the knee out of it to really see what's happening at the ankle. And that's very hard to do, right? So I would say for the most of us that are in clinics with limited access to resources and limited testing capabilities, I think if you use the calf raises, and you know what too, there is actually a calf raise app. And it's very slick. You can use it on your phone. There's normative data for calf raises, how many you should be able to get. You just have to be picky about their form.
Mm-hmm.
And then not only can you do the heel raises, but then again, reps to failure, like what's their ultimate failure point? And that's, to me, is more important for the people that have to do more sustained running, like your runners and sprinters and things like that. Because if they don't have that capacity, if we go back to Dr. Dye's, envelope of function, we try and move capacity and tolerance to the right. And, if they don't have that, that's going to be a problem. So long-winded answer, sorry, but.
No, but because I think it's the force plate stuff, but then also do not forget backing up, seeing the forest for the trees and look at them in the coronal plane and make sure that if they're trying to get that 8th, that 10th, that 15th heel raise, that all of a sudden what you would be scared to death with as far as a valgus moment at the knee when you're dealing with an ACL, that you don't forget that with an Achilles, because a weak hip, a post tib and an FHL and an FDL cannot make up for a weak hip, and it will make them seem like they don't have plantar flexion, when in reality, the Achilles and those short plantar flexors cannot make up for weak glutes. So
great points, guys.
Yeah, 100%. I haven't even talked about that piece, but that's always an integral part of my programming, proximal hip and core work.
Yeah,
and those kind of things.
Okay. Let's move to the second, get at least a couple questions in on the second article. We could have literally, I think, just done the first article the entire hour. So let's jump to this one. Return to play after surgery for isolated unstable syndesmotic ankle injuries, West Point grade 2B and 3 in 110 male professional football players, a retrospective cohort study. Let's start off with you, Kirk. Can you explain to the people that maybe don't really fully understand why the syndesmotic sprains are like just so much more problematic than just your typical lateral ankle sprain you see?
Yeah, I mean, I think the problem with them is most often is that they're underappreciated, in the sense that they're there, but they don't swell like a lateral inversion sprain does. And therefore, because they don't swell, it's like, oh, you just kind of tweaked it.
Not that bad.
It's going to be okay. But man, they hurt a whole lot more. And then the ability to be able to push off, and that stability or lack thereof between the tibiofibular joint down at the ankle, and then ultimately that instability or the inflammation from that instability's effect on the FHL, which runs right down along that interosseous membrane, that is what ultimately prevents them or discourages them or disables them from feeling like they can backpedal, get up on their toes, really push off. Yes, when it's bad enough, they'll complain about it in the front. And almost always those ones that say persistently painful in the front are the ones, just above the ankle joint along the syndesmosis. Those are probably the ones that are going to be unstable. It's the ones that still have the persistent, subtle, but yet, painful symptoms in the back that are the ones that are hard. Even when they're stable, it's a 2A or a 1, but they still have pain along their FHL and they feel like they can't backpedal and push off and jump. That's the hardest with them.
Yeah. Can you explain, do you mind, while you just mentioned it, do you mind explaining the differences that they described here between the 2A, 2B, and 3?
So the considerations of, grade 1 is just an AITFL only injury. So the anterior inferior tib fib ligament. A 2 is in disruption of that in the interosseous ligament or the interosseous membrane. It's an A if it's deemed stable, and it's a B if it's not. But I will tell you, that's the $1 million question with any of these athletes, because it's the grade 2s, and is it going to be okay and it's just going to take time? Or now with everything that's been out there with Tua and everybody else, and Bowers for the tight end for Georgia, look, well, why not just get a tightrope and I can come back in 4 to 5 weeks? The 3s are obvious. That's the disruption of everything and or associated with a fracture. Those get fixed 100% of the time. But that's the deal there. The key here is the ability for it to be stable enough to be able to ultimately heal, but yet to be able to satisfy the desires of all these athletes and the pressures on them of being able to try to get back as soon as possible, versus, hey, you need surgery. And then also the reality that when we attempt to immobilize these and protect them, are things like a boot really protective of a high ankle sprain? My answer is no. Yeah. So we can get into that in a little bit.
What We can get to that in just a second here, but I was going to ask you too, the tests they use to help like diagnoses, they use the squeeze test and the ER stress test. Do you use both of those? Do you use any other test? Are there any additional tests you use when you're looking at these?
So those two definitely. I mean, those are provocative means by which to test this. Now, obviously, for someone that's pretty painful, they will start firing a lot of things to resist you from trying to hold their lower legs still while you take their foot and forcefully externally rotate it. But I also think something that's important, at least early on, is how far tenderness do they have along the anterior syndesmosis up from the ankle joint. So, Norm Waldrop and I talk about this quite a bit when we lecture to AOFAS or AOSSM. We get concerned about ones that are 4 or 5 centimeters or more. So when it's 4 or 5 centimeters or more, and those other tests are positive, but not always the case, and if it's associated with significant medial type pain, then all of a sudden you become more concerned about, well, is this an external rotation mechanism that's bad enough to where not only is it the syndesmosis, but they've also ruptured off the anterior superficial portion of their deltoid complex, which from our NFL studies that we did on this is actually the first thing that goes even before the syndesmosis, is that they have an anterior deltoid injury before they tear their AITFL.
That tenderness test, is that what it's called? The tenderness test? Is it called the tenderness?
You're talking about just like that
test?
palpation along the anterior aspect?
There's a name for it, right?
I don't think it has a name.
Okay, I thought it was called like the tenderness length test or something like that.
It may, and if it is, I'm ignorant of it.
Yeah.
But there is a very unique test that Ned Amendola came up. So obviously we're talking about things that are acute. The chronic ones sometimes are a problem because you got somebody that's come in, they've had pain, they just can't feel like they can push off, and it's now 2 months, 2.5 months.
Mm-hmm.
So there's a syndesmotic taping test where you can take pre-wrap 2 centimeters above the joint, and you can wrap circumferentially fairly tightly, tape, and take someone, and you can't do it for very long, but in clinic who otherwise can't do a single limb heel rise, that all of a sudden, because of that stability you will create, will be able to do a single limb heel rise. And then within 2 to 3 minutes say, hey, cut it off because their foot starts to swell from all the venous enlargement. But those are the tests that we tend to use, short of, hey, what's the MRI show and do we need to scope it?
Yeah. Some of the criteria they use to determine, or at least in this study, the criteria they used to determine when people could return to rehab they were just strictly functional measures. And so I guess my question, Dan, you could answer this too. Do you still use objective measures? I mean, do you look at their range of for syndesmotic injuries? Do you look at their range of motion? Do you do a figure 8 looking at their swelling to see if it's down? Do you do manual muscle testing, or do you just throw that all out and just go with, can they walk and can they jump or can they do something?
It'd be a sacrilege to not go through the functional testing algorithm, as you know, Manske. So the circumferential figure 8 measurement, start at the navicular, around the foot, inferior to the medial malleus, and then around the lateral, and then meet it there at the beginning. Range of motion, of course. I also check closed chain dorsiflexion. Now that's not acutely, of course, as you can make somebody very irritable if you force dorsiflexion, but certainly down the road, the normative data has shown like if you do a half kneel and you put a tape measure and you move your foot back and you try and like closed chain dorsiflex tibia, like knee to the wall, it's just shy of 4 inches is considered normative. I'm not saying that's what you have to do, but certainly using the other side as a reference point is something to look at and something to look towards. Because as we've talked about kinetic chain before, the body's a remarkable machine. If it needs that dorsiflexion at that talocrural joint, if it doesn't get it, it's going to find it somewhere. Yep. So either you subtalar evert and the talus collapses inward and the tibia follows, and now you dynamic valgus and tear an ACL. So eventually we have to make sure we get that back.
You do the same as you're saying. I guess when I asked the return to play question earlier, but I think we got somehow sidetracked and we didn't really talk about it fully about like what kind of test you look at when people return to play. So I asked you earlier in the Achilles tendon injury section. Now we're at syndesmotic injuries. Are they the same? Are they different? Are they the same thing you do at the knee? How do they differ?
So for me, I want to test all 3 planes, and I do the stair hop test, that medial lateral hop test, 30 centimeter, the ACL is 40 centimeter, ankles 30 centimeter. And the other one is that 9 meter, 6 meter, 9 meter hop test. Sorry, I'm getting tests confused in my head, but it's a figure of 8 hop. and it's
Okay.
2 trips and a figure of 8. And the reason why I like that, because it adds the transverse plane components. You got to turn around the cone. And then essentially that, again, clinically based tests, anybody can do them anywhere. That's why I talk about them a lot. It's not perfect, doesn't tell you everything, but in the absence of force plates and all the toys, you can still do a good job, right? So you're just comparing side to side 2 trips for the figure of 8 hop test.
You ever do you guys have at your place, Dan, do you have an isokinetic machine?
We do. I've done it a few times, but I'll be honest with you, the Humac, at least for the Humac and the ankle setup, is really
Difficult.
complicated.
Yeah.
Yeah, and I don't know how reliable because it moves a bit. Like I don't know how, like I can lock a shoulder in, I can lock a knee in. I mean,
The
heck, I
ankle's
did
a
a
little-
bicep on a strongman once. I can lock all that in, but the ankle, man, it's just a little it too much artifact, I think, to make sure I do it right.
Just so everyone knows, Dan's not a spokesperson for the human.
I'm not. Any of the stuff I
Apparently
mentioned tonight, no conflict of interest, no disclosures. But it'd be a
And,
lot cooler if I was.
yeah. Wouldn't it?
Yeah.
Wouldn't it? So I guess anybody, I'll throw this one of these last couple of questions. Anyone can, so these syndesmotic ankle sprains, can we prevent them all? And what do we do to prevent them? You're shaking your head, no, doc. They can't be prevented, can they?
Yeah, and I want to be careful. So because I am involved with a project that's a consideration of how cleats engage with the surface, because I do think that there's probably something there. So I'll just leave it at that. But no, not all these can be prevented. I mean, we can talk about hip drop stuff, which certainly we've looked at from an NFL standpoint. And yeah, I mean, when you are loading someone and rotating, there's going to be something that has to give. But look, for these athletes to perform as they need to, you can't just duct tape their ankle together and be like, well, hey, well, I'll be darned if we're gonna, have the ankle go and we'll let the knee or the hip or something else go. And the other problem is that, I mean, this is not unlike an ACL. Ultimately, this is a rotational injury. So I think we can do a pretty good job at inversion, eversion, because we're able to control that with the hind foot fairly well. But controlling rotation, you have to have something that would drive into the tibia to be able to prevent it relative to the bones below it or the bones above it from rotating. So an ACL brace will not prevent an ACL tear, and there is no brace that will prevent a syndesmotic injury. Can we mitigate it by the type of field, the type of cleat, the strength of the hip, all these other things, as far as maybe being able to dynamically resist a rotational moment? Yes, but goodness gracious, now this is soccer. They list it as football, but this is not American football as we know it. But in like football, for example, you have another being that is trying to rip you rotationally down to the ground. There's only so much that your muscles are going to be able to resist, and your bones and ligaments will be able to. So no, we can't prevent all of them.
Yeah, we maybe decrease risk, and there's they don't, we don't, are there studies showing decreased risk by doing certain exercises for these type of ankle injuries? Like they have the knee, you have the preventive programs for the knee that show there's some decreased risk. It doesn't prevent them, but there's plenty of studies showing that if you do, certain set of activities, it decreases the overall risk. Are there studies like that? And there's probably got to be.
I think there are for inversion sprains as it relates to court sports, but as it relates to cleated athletes and rotational injuries, I am unaware of them.
Just not there.
Yeah, that's a biomechanical injury, right? So there's nothing neuromuscular that you could do to prevent the cleat being stuck in and then doing a transverse plane rotation.
This is why ultimately in this scenario, why the NFL spent so much money looking at turf. Why we've dug in so deep for the last 8 years on cleats, and we tell, there's a poster every year that we give out to the PAs and the players that are in every locker room and every equipment manager's room as to cleats that do not release. So, everything's always been about, man, I want traction.
Mm-hmm.
The reality is that there is a pathologic amount of efficient traction that creates a liability to the limb. So there is a time at which you need your cleat to let go.
Yeah.
It will certainly do that when it's a sod soil interface, a lot easier than it will be a synthetic fiber mesh with a cleat dug into it. So that's why they do all the surface testing and everything else and infill and all that other stuff. So
great. Well, guys, we got like 2 minutes, I think. Does anyone have anything, any last questions you want to ask Doc or Dan? It's been a great session, guys. Thank you very much. We really appreciate it.
Yeah, just big thanks for coming and sharing your knowledge.
Thank you for
Yeah,
having
no,
us. Holy cow, hope it was helpful and wasn't a colossal waste of your time, for at least from my end.
That was
Definitely,
awesome.
definitely not a waste of time. Definitely not a waste of
Nope.
time, Danny.
Just by the fact that I have a whole page of notes written down, I think we need
Yeah.
more foot and ankle stuff on Journal Club.
Same here. I think I do too.
well,
Not something I see regularly at all.
as the plug for the foot and ankle guy, look, there's a huge burden of these injuries that are managed. So I would be more than happy to come back in if I could have Dan to
Back you up.
support us.
Definitely, we'll have you back for sure.
Dr. McCullough, would
What are you doing? What are you doing next month, by the way?
Let's do it.
Hey, Dr. McCullough, I'm supposed to tell you hello from Chris Walbert. He's one of my favorite students too.
Oh yeah, absolutely. Yeah.
Yeah.
Gosh, this is a small world.
All world.
Well, so if Dan was your student and Chris was your student, I'm understanding even more about who you are, because two excellent PTs. Is there anyone else you want to train?
I don't know. I'm not sure I'm up to it. I'm going to retire pretty soon, so that's all good.
All right.
Dr. McCullough, before we go, will you please provide the tip that you gave at our last symposium that was kind of about the way boots work and how you give people arches because of the way they're structured?
Yeah,
I
please.
think, and also night splinting after a sprain because of people sleeping the way they do. I thought that was a comment that really resonated with a lot of people that I don't think people think of.
So yeah, and I meant to bring it. So, quickly, the problem with boots, as we think about them, we cannot stock right and left-sided boots. I mean, it's impossible.
Right.
You're lucky to even have a boot to a facility that you go to. So the problem with that then is all of us in our boots are very under-supported. We're very rigidly immobilized as far as 90 degrees at the ankle. But as it relates to the hind foot and whether or not you can pronate and supinate and whether or not the arch is supported, particularly for Lisfranc injuries, for medial-sided deltoid injuries, because of the involvement of the medial side as it relates to a high ankle, in all of these, I can't overemphasize enough how important it is to try to give them an insert in their boot, because it tries to help, if nothing else, to stabilize that anterior superficial deltoid component, and it prevents some of that subtle rotation and pronation that occurs. So I think it's really critical for that. And I mentioned the whole boot disease phenomenon. The problem is whether it's a lateral ankle sprain or some of these other issues, one of the biggest things that we fight early on is plantar flexion contracture of the posterior, soft tissue to the capsule, but then also up the leg. So I tell folks if they're wearing a boot during the day, unfortunately, they have to wear a boot at night. Because what we don't want to do is have the cure end up creating another problem. Because what do we do to treat plantar flexion contractures and Achilles issues and plantar fasciitis? Well, we give people a night splint. So, there's nothing that's going to create that potential problem more than a boot during the day where we don't naturally stretch. So that's why, whether it's a night splint, even when they're in an ankle brace, just to maintain that muscle tendon length tension in that 90 degrees. I mean, if nothing else, for a lateral ankle sprain, it keeps the ATFL and the ankle in that position to where it's not plantar flexed and inverted. So, I mean, those are critical things, at least for our locker rooms, that we try to get compliance on. Are we 100% no? But I think it helps to prevent some of the other problems, and it actually enhances their means of recovery. But the insert in the boot thing, don't let your athletic shoe be more supportive of your arch and your foot than the $250 boot. So.
Yeah. Thanks for mentioning those. I thought those would be helpful parting things before everybody goes as little pearls.
Yeah.
Right, guys. Ash, you need to do you think close it out?
I think Voight had the wrong time zone or something. I don't know.
He's just now getting on.
He said he's been in the background the whole time. So
yeah, he has been. No, just appreciate you guys both coming on, and this has been great. I will get this and September's up and posted. I've already learned a lot, and we will definitely have you back. So much appreciated. Thanks everyone that joined us tonight, and everyone have a great night.
Thanks,
Great.
everybody.
Thanks, guys.
Everybody.
Appreciate it.
Thank you.
See ya.